This is a primer on lung ultrasound for COVID-19 Lung Disease Center. And I think the big question is, if you're not doing lung ultrasound right now for pneumonia, why should you want to take the time to learn this? Number one, chest x-ray, just for pneumonia in general, lags behind clinical presentation. I think we all have seen that multiple times in our practice. The literature says that the sensitivity for a 2-view chest x-ray is about 70% or so you're missing a third of pneumonias right at the top, and there's also issues for exposure and transportation of the patients into the radiology department. More significantly, CT, because it takes 2 hours to decontaminate the scanner after someone who's COVID positive or potentially COVID positive has been in the scanner, that's going to mean really significant downtime and delays for all of us in the emergency department and the rest of the hospital. Additionally, there's a risk of transmission with transport in terms of going to a different part of the hospital, not to mention the person who's transporting them. And it's going to be important to maximally leverage our and protect our hospital resources. So we are definitely not outliers in any way with point-of-care ultrasound, as particularly lung ultrasound. As you can see here, you may have seen this on CNN last week. This is a doctor who actually has been kind of cataloging his experience of having contracted coronavirus with his own handheld ultrasound. He's using a Butterfly here with a day-by-day sonographic journal. Lung ultrasound, that is, really just a critical modality from everything that we're hearing from our colleagues in Italy and Spain and China and other places that have been hard hit by COVID. Lung ultrasound is absolutely indispensable in the diagnosis and monitoring progression of this disease. It's quick, it's sensitive, it's repeatable, it doesn't expose anyone else. You can certainly use it to rule out other diagnoses. So we're the ones who are on the front lines. We're making decisions about who's coming in and who's not coming into the hospital. And at the very minimum, I would say it's just another very important data point that we can use to make those decisions and really answer the question, what do this patient's lungs look like? So COVID is not the first time that we've looked at ultrasound for pneumonia. In fact, we've got 30 years of really solid data showing that it's just all of those things: extremely accurate, reproducible. It's been validated in multiple meta-analyses. It's shown to be superior to chest x-ray in pleural effusion, pneumonia, pneumothorax, and pulmonary edema. And here are some of the numbers on sensitivity and specificity if you look at those numbers there for pneumonia in particular. So there have been 3 patterns that have arisen in COVID pneumonia particularly, and these are fairly similar for viral pneumonias, but in the studies that have come out so far, and they are, number 1, B lines that are bilateral and posterior. Number 2, changes in the pleural line. It's irregular, it's thickened, and we'll show you examples of that. And 3, consolidations that can start out very just small subpleural consolidations, and then they could become larger. Of course, infection control is of primary importance to all of us, and we recommend using the same PPE as you would any close contact. And so that would be an N95 respirator, a face shield, a gown, gloves, bouffant versus a capper. And we recommend wiping down the probe and the ultrasound machine, whether you're using a handheld or an export, before your scan as well as after your scan. So how to scan the lungs? Well, we know that COVID pneumonias are bilateral and mostly posterior and inferior. So what we recommend doing is starting with the patient facing away from you, so you're behind the patient, and just applying a ribbon of gel basically from the apex of the lung all the way down to where you think the diaphragm is. And just scan either in a straight line down, or if you wish, to kind of a more of a snaky line down all the way down from that zone 5 up here, just medial to where the scapula is going to be, all the way down into zone 6, which is the main area where COVID lesions have been found. And really take your time in zone 6, and we recommend kind of a lawnmower technique where you're covering a lot of surface area of this R6 above where the diaphragm is. Next, you're going to have the patient raise their arm, and you'll stand right next to them and scan again from kind of the apex up here right by the axilla all the way down through the third zone and to the fourth zone here, and you'll see the diaphragm typically here at the bottom of zone 4. And lastly, anteriorly, you're going to start just distal to the clavicle and sweep your probe in sagittal orientation all the way down through the first lung zone, down through the second lung zone, all the way to the diaphragm here, which you can usually see fairly clearly on ultrasound. And if there's something that catches your eye, something that looks abnormal, be it the pleural line or focal B lines, pause in that area, take a look at it, be sure of your diagnosis. You can change the orientation of your probe to transverse orientation to get a better look at it or a better look at the pleural line. The scanning protocol, once you've done a few of them, typically takes about 3 minutes total to do the entire surface area of the lung. Some people have likened scanning the lung to painting with a roller. If you see an area that looks abnormal, then go a little bit slower, scan back over it, possibly in a different orientation, just to make sure that you're definitively seeing what you think you're seeing. And in the interest of time here, I think I'm just going to speed through this particular one, but this is an example of scanning through the lung protocol that I've just described. 5 and 3 and 4, and then 1 and 2. So to optimize your image, what you can do is kind of rock the probe. You can slide the probe in between rib spaces, and you can fan or tilt one way or the other. And usually you kind of hit a sweet spot. It's almost like tuning into a radio station where you see all the artifacts come out, and when you're totally perpendicular to the pleural line. A couple of helpful hints. We tend to have the convention of having the probe marker going up toward the patient's head, scanning in a sagittal or longitudinal orientation. And it's helpful to have the probe 90 degrees to the ribs or to the pleura, and that's what's going to bring out the artifacts. It's also helpful sometimes to anchor your hand or your third and fourth fingers on the patient's body. And so when you put the probe on, you're going to see typically this, and these are going to be A lines, and they're equidistant lines. They're a reverberation artifact, and they basically mean aerated lung. Now, if someone's in respiratory distress, doesn't mean that they don't have any pathology. They could have COPD, they could have asthma, they could even have a PE, but it just means that there's air in their lung. Versus the primary pathological artifact in lung ultrasound are B lines. And B lines are these vertical hyperechoic lines. They typically mean edema or something that's not air in the interstitium. And they are actually tightly packed A lines, but because there's not air in the interstitium, that could be fluid, it could be scar, it could be infection, then that kind of bounces around the sound waves, sort of like a pinball machine, and they get back up to the pleural line and back and forth and back and forth and back and forth, those sound waves, until they kind of produce this vertical line that looks almost like strobe lights in the fog. In order for there to be pathological B lines, you can see 1 or 2 here and there sometimes, especially if you're off angle from the pleural line. But you need 3 per footprint of your probe. You need to go down to at least 13 or 14 centimeters, and they should go to the bottom of the screen and erase all A lines for them to be definitively called B lines. And so really keeping things simple, it's typically this pattern versus this pattern over here versus this pattern over here. And I hope by now you would say that that's a B line and that's an A line. So not only are there parenchymal or interstitial pathology seen in COVID-19, but there's also pleural abnormalities. So it's important to kind of get your bearings and know what the landmarks are by the pleura. So here we've got a linear probe, and we're taking a look here at the pleural line itself. This is the superior rib with shadow. Here's the inferior rib with shadow. And this is the pleura. This is the point where the visceral and parietal pleura meet. You can see that it's sort of like ants on a logs, ruling out a pneumothorax in this particular lung space. So again, back to the three patterns in COVID pneumonia: B lines, pleural line abnormalities, and consolidation. So there's just been 2 studies so far on COVID and lung ultrasound, and the first one was by Huang, came out the end of February, and they basically found these findings, which were irregular pleural lines, subpleural consolidations, B lines, and localized pleural thickening. The second study was also a fairly small number study, this one by Peng, also from China, which essentially showed the exact same thing: pleural line abnormalities, B lines, and consolidations. And this one also followed patients through their hospitalization, showed that A lines can be found once the patient's improving and in their convalescence. So a couple of examples here. Here's a CT on the left, and here is the B line. So again, they can be multifocal, they can be confluent, they can be sparse, they can be a so-called waterfall sign where all you see is B line, but basically they're rising from that pleural line and going all the way down to the bottom. And they typically correspond with ground glass opacity seen on CT. Rib shadow, pleural line irregularities, B lines coming down. These are a little more sparse and kind of multifocal. Here's a little bit more confluent in this rib space right here, with some thickening and irregularity of that pleural line as well. These are scans from patients who are currently hospitalized from a colleague, friend in northern Italy, who had wanted us to get this information out there. And you can see these are more confluent B lines. This was a hypoxic patient who had an oxygen requirement when he presented to the emergency department just a few days ago. Confluent B lines, again, thickening of that pleural line. Here's another example, and another side of his lungs, a little less confluent, but still very much interstitial pattern with a little bit of that thickening and irregularity of the pleural line. Here's another patient who also was mildly sick, just needed a couple of liters of oxygen, is what he said at presentation in the emergency department, and is now in the IMCU, having been hospitalized for the past 4 days. Patient, again, sort of multiple B lines, that thickening, kind of irregular looking pleural line. And here on the left side of his lungs, you can see the heart over here, but again, fairly confluent looking pattern with some thickening and irregularity of that pleural line. It bears noting that B lines don't exactly always mean COVID. So certainly they can be present in viral or bacterial pneumonia, especially when they're coupled with other ultrasound findings such as that thickening of the pleural line or subpleural consolidations that I'll show you, or other consolidations. But certainly seen in pulmonary edema. I think many of us have already seen this in decompensated heart failure. You get bilateral B lines, but typically you get a really crisp pleural line. And also those B lines tend to start very regularly in dependent lung fields only, and are often seen with pleural effusions, which COVID pneumonia is not. Interstitial lung disease can also create B lines as well as pleural line thickening, so those can become trickier, and likely chest x-ray might be needed for any kind of definitive diagnosis in those patients. But of course, everything is kind of interpreted within the clinical context in lung ultrasound. And also ARDS can produce findings that include B lines and thickening of the pleural line, but there's also skip lesions, as is seen in chest x-ray and CT in these patients. So pleural line abnormalities, here, this disease is initially starts at the terminal alveoli in peripheral areas, and those are areas that are touching the pleura, which is the reason why the lung ultrasound findings are so sensitive. So here you can see kind of an irregular pleural line here. Here's a very focally irregular pleural line, and here's an example of that lesion that's touching the pleura here. This is a little bit more subtle, but in real time, you got some B lines coming down here, but just like a little bit of subtle thickening here of the pleural line. And here's less subtle findings here, and a sicker patient, ICU patient, here with that very disrupted pleural line here, and very, very disrupted pleural line here. Here's an example of a patient that we scanned just last week with viral pneumonia, who ended up having this finding, which is a subpleural consolidation. And it almost looks like someone kind of took a bite out of that lung right there. As you can, if you can appreciate that, like here's the pleural line. This is all rib shadow over here, pleural line, and then this sort of circular bite out of that pleura. And those are often associated with viral pneumonias. And here's a still of that pleural line, and then a big bite out of that pleural line, and then resumption of the pleural line here, and that's a subpleural consolidation. So sometimes those subpleural consolidations can actually get bigger. So here's the curving of the pleural line, and then you've got this kind of tissue-like, almost echo pore area here before the B lines start distal to it. That's an actual consolidation itself. And that's what a consolidation looks like on ultrasound. Here's another example of it here. You've got the pleural line, and then all of a sudden it's just kind of like this sort of darker area with these bright white spots in it. Those bright white spots are actually air bronchograms, just like you would see on a chest x-ray, but that's what an air bronchogram looks like against the background of a consolidated lung on ultrasound. And then you've got some B lines distal to it right there. And so that's a consolidation. This is a more significant consolidation. This was actually a patient who had a bacterial pneumonia. Just for orientation's sake, this is the diaphragm here, this is the liver, and this is the spine, which typically stops right here at the diaphragm, but it continues on because the lung consolidation is transmitting those sound waves all the way down. So if you can see the spine, that's called the spine sign. But here, this consolidation here, it almost looks like tissue, and there's a couple air bronchograms right in the middle of it there. And lastly, this is a consolidation here with a bunch of air bronchograms and some localized pleural effusion above it, which is also typical in COVID-19. Here is an example of a consolidation in a COVID-19 patient. You got this kind of echo pore tissue-like density right here. And here with a linear probe, you can see an example of a consolidation just above the diaphragm here. This is actually spleen. This is all consolidated lung. This is a very, very thin cachectic patient who had aspiration pneumonia, and these are air bronchograms here. So pleural effusions have been described in COVID, but they're very rare, and they're typically just around the consolidations, right around the pleural line. So they're quite small. Here would be an example of a small pleural effusion right here, and the key to diagnosing a pleural effusion is seeing where that diaphragm is. Now, if you saw something like this, which is a very large pleural effusion, maybe associated with like congestive heart failure or malignancy, then, and that's atelectatic lung sort of flapping in the breeze of that huge effusion, that's likely not COVID pneumonia. Those have really not been described in the literature, and that would point you toward an alternative diagnosis. Here's other positive that have just come from patients currently hospitalized in Italy, kind of bilateral B lines here, some thickened irregular pleura, and again, bilateral B lines. This is not quite as much of an interstitial burden as we've seen on some of the other ones, but certainly there. Here's our workflow that you can see offline for the people who in our tents we're going to be swabbing. And I thought we'd just end with a few cases. So tent case 1, if you're seeing a patient who's, let's say, 61, got some comorbidity, COPD, diabetes, history of treated cancer, has got 3 days of shortness of breath, cough, and fever, here are the vital signs. Normal work of breathing, doesn't really look sick enough to come in the emergency department or be admitted. You think you're going to discharge this patient home. You do the lung ultrasound, and this is what you find: bilateral posterior B lines in zone 6. So still the patient looks good. They don't need to come in. They're not to be admitted. But this is the kind of person who's going to be flagged for telemedicine follow-up. Case 2 is a similar kind of presentation: patient with risk factors, COPD, coronary artery disease, who's had shortness of breath and cough. Those are the vital signs, SAT of 95%. This person's a little bit working to breathe a little bit harder, kind of tachypnic, and you think that they need to come in the emergency department for further evaluation and testing and possible resuscitation. Well, while either in the tent or in the emergency department, you do your lung ultrasound with a butterfly, and this is the pattern that you see in all lung zones, zones 1 through 6. And this is an A-line pattern. That's the pleural line, and you've got this A-line reverberation artifact. And with this, given the sensitivity and specificity of this test and its excellent negative predictive value, you can be pretty sure this patient does not have pneumonia, nor do they have CHF, and you diagnose the patient with a COPD exacerbation. This is an example where you use your ultrasound to establish an alternative diagnosis and rule out pneumonia as well as CHF. Have improved utilization of resources in our hospital. Tent case 3, this is a 50-year-old who's got a history of homelessness, methamphetamine use, and cigarette smoking use, who's looking kind of sick, shortness of breath, cough, and fever. Those are the vital signs with a SAT of 90. Definitely increased work of breathing. You think the patient's for sure going to need to be admitted, kicked back from the tent into the ED to get some resuscitation, likely admission to the hospital, given the oxygen requirement. So number 1, the patient's lung ultrasound should occur in the emergency department. This is a sicker patient. Don't delay transport of this patient into the emergency department just to do the lung ultrasound. Send them in, get them appropriate care, and do the lung ultrasound once they're being observed and cared for in the emergency department. And number 2, this is what you find. So they've got bilateral posterior B lines in zone 6 and in multiple lung zones. And you can see here there's actually a consolidation that they have, and they had it bilaterally here. So this is going to be a sicker patient. These consolidations have been associated with a poor prognosis, with earlier intubation. Keeping things simple and getting back to the basics, really it comes down to, are there B lines? And if you can appreciate changes in the pleural line, that's great. Or are there not B lines? Is there an A line pattern there? And I think just with that alone, you're going to go very, very far with lung ultrasound and take great care of your patient. It's an eminently learnable technique. It's repeatable. It's highly sensitive, and you can get truly actionable, excellent information at the bedside without having to overburden our very limited resources in the hospital.